Hello, my name is Amy Lucero, and I'm a student of social work with National University, and this is my presentation titled Explain a Differential Diagnosis Case Study. This presentation will examine Lindsay's case using the DSM 5 diagnostic framework. The purpose of this analysis is to apply systemic differential diagnosis to rule out competing disorders and to identify the most clinically supported formulation. Given the client's history of bipolar disorder, borderline personality disorder, polysubstance use, and recurrent emergency room visits, a careful diagnostic clarification is necessary. The DSM 5 provides standardized criteria for diagnosing mental disorders in order to improve diagnostic reliability and clinical consultancy. Diagnosis requires more than the symptom presence. Clinicians must evaluate duration, severity, functional impairment, and rule outs. Differential diagnosis is particularly important in emergency settings where symptom exaggeration, intoxication, withdrawal, personality pathology, and acute stress reactions overlap. The DSM 5 also instructs clinicians to rule out substance induced disorders before diagnosing primary mood or psychotic disorders. In Lindsay's case, polysubstance use, inconsistent reporting, and recurrent crisis presentations complicate interpretation. Therefore, diagnostic formulation must integrate history, behavioral observations, laboratory findings, and collateral documentation rather than relying solely on self report. Lindsay is a 34-year-old female admitted to the hospital for cellulitis treatment following a recent car accident. At admission, she expressed suicidal ideation, prompting a psychiatric consultation. Her psychiatric history includes bipolar disorder, borderline personality disorder, anxiety, and polysubstance abuse. She has had 3 emergency department visits within the past month and a documented history of disruptive behavior and leaving against medical advice. During the assessment, she was alert and oriented. She was eating and not in acute distress. She reported a suicide attempt 2 weeks earlier. However, prior documentation described the incident as a car accident with no mention of a suicide intent. She denies current hallucinations but previously reported auditory hallucinations without observed response to internal stimuli. Substance history includes alcohol use and recent methamphetamine positivity. Based on the presenting data, several diagnoses were considered, including bipolar disorder, major depressive disorder, substance and medication induced mood disorder, borderline personality disorder, psychotic disorders, and malingering. These conditions were overlapping features including suicidality, impulsivity, mood instability, and behavioral dysregulation. The DSM 5 directs clinicians to first rule out substance induced causes before diagnosing primary mood or psychotic disorders. Additionally, personality disorder must be differentiated from episodic mood disturbances. Malingering must be considered when inconsistencies and potential secondary gain are present. Each diagnosis systematically evaluated against DSM 5 criteria to determine whether Lindsay's symptoms reflect a primary mood disorder, personality pathology, substance related condition, or intentional symptom fabrication. Bipolar disorder. Bipolar disorder requires at least one lifetime manic episode characterized by elevated or irritable mood and increased energy lasting at least 1 week and accompanied by additional symptoms such as decreased need for sleep or grandiosity. Lindsay carries a prior diagnosis and is prescribed Lamictal and Abilify medications. These are commonly used in bipolar disorder management. However, during this admission, there was no documented evidence of mania, hypomania, or clearly defined major depressive disorder meeting full DSM 5 criteria. Her presentation appears behaviorally organized and mood symptoms lack documented duration and severity thresholds. While a historical bipolar diagnosis may be valid, there is insufficient objective evidence to conclude she is experiencing an acute bipolar disorder during this hospitalization. Major depressive disorder. Major depressive disorder requires 5 or more symptoms over a 2 week period, including either depressed mood or loss of interest with clinically significant impairment. Although Lindsay reports suicidal thoughts, documentation does not demonstrate persistent depressed mood, psychomotor changes, or sustained neurovegetative symptoms. During assessment, she was alert, she was eating, and not exhibiting overt depressive psychomotor slowing. Additionally, substance use and personality pathology provide alternative explanations for suicidal ideations. Because the full diagnostic threshold is not clearly met and symptom chronicity appears interpersonal rather than episodic, major depressive disorder is ruled out as the primary diagnosis at this time. Substance and medication induced mood disorder. Lindsay tested positive for methamphetamine and reports alcohol consumption 3 to 5 times weekly. Methamphetamine can produce mood lability, paranoia, irritability, and suicidality. While alcohol misuse increases impulsivity and depressive symptoms, the DSM 5 states that substance induced mood disorders occur during or soon after intoxication or withdrawal. Although current intoxication is not documented, chronic stimulant use may exacerbate emotional instability and suicidal ideation. Given the temporal relationship and active substance use, substance induced mood disturbance remains a significant contributing factor. However, it doesn't fully explain how explain her long-standing interpersonal instability and recurrent crisis presentations. Borderline personality disorder. Borderline personality disorder is defined by pervasive instability in relationships, self-image, and affect, along with marked impulsivity beginning in early adulthood. Lindsay demonstrates chronic suicidality, recurrent emergency department utilization, impulsive departures against medical advice, interpersonal mistrust, and inconsistent self reporting. Her statement about people stabbing me in the back suggests interpersonal sensitivity and possible fear of betrayal. Chronic suicidal ideation over 2 years suggests a trait level vulnerability rather than a time limited mood episode. The pattern of recurrent crisis and behavioral dysregulation is consistent with borderline personality disorder as a central organizing diagnosis influencing her healthcare engagement. Malingering. Malingering involves intentional fabrication or exaggeration of symptoms for external gain. Lindsay's inconsistent reporting of a suicide attempt and documented drug seeking behavior raises concern. Additionally, prior hallucination reports lacked behavioral confirmation. However, malingering requires clear evidence of deliberate deception, motivated by tangible external incentives. While suspicion exists, available data does not conclude or demonstrate intentional falsification. Personality pathology and substance misuse may better account for inconsistencies. As Roger as Rogers and Benger uh, caution, premature labeling and malingering can bias treatment and undermine therapeutic alliance. Therefore, malingering is considered but not formally diagnosed. Psychotic disorders. Schizophrenia spectrum and other psychotic disorders require persistent delusions, hallucinations, disorganized thinking, or negative symptoms independent of substance effects. Although Lindsay previously reported auditory hallucinations, there is no documentation of her responding to internal stimuli. During their assessment, she denied hallucinations and demonstrated organized thought process and intact orientation. The absence of objective psychotic symptoms and the presence of substance use make primary psychotic disorder unlikely. Therefore, psychotic disorders are ruled out in favor of alternative explanations such as substance effects or personality related perceptual distortions. Final diagnostic formulation. The most supported primary diagnosis is personality disorder based on pervasive interpersonal instability, chronic suicidality, impulsivity, and recurrent crisis behaviors. Substance induced mood disorder remains a rules out contributor to acute symptoms, exaggeration, exacerbation. Bipolar disorder cannot be evidence of mania. Treatment implications. Treatment should prioritize DBT, which is the evidence based intervention for borderline personality disorder. Integrated dual diagnosis treatment addressing stimulant and alcohol misuse is essential. Medication adherence should be verified objectively due to inconsistent reporting, and suicide risk management should focus on chronic risk reduction, crisis planning, and structured outpatient support rather than repeated inpatient admissions unless imminent danger is present. An interdisciplinary approach that includes psychiatry, social work, and substance treatment services improves the outcomes in complex comorbid presentations. And these are my references. Thank you.